Going beyond the headlines. Asking the questions you want answered. Exploring government policies and how they impact you. We are delving deeper.
Good evening and welcome to Delving Deeper. I'm your host, Sunil Lalla. Joining us this evening is the Minister of Health, the Honourable Terrance Deyalsingh. Good evening, Minister, and welcome back to the show.
Good evening, Sunil. Good to be here.
We continue to see dengue cases rising. Yes. What would there be in terms of the ministry declaring an outbreak of dengue? Are we in that stage just so far?
We are in an outbreak because the figures are higher than the average over the past few years. The last time we saw these type of figures would have been 2014 to 2017. So this is an outbreak because the figures are above what we have seen in the past.
Why is this happening at this point in time?
So if you look historically, dengue tends to come and go in cycles of between 7 to 10 years. So that's one of the reasons. Another one of the reasons, as we try to explain, is that during the COVID years when people were not outside and were mainly inside, people were not being bitten by mosquitoes. So therefore, the natural immunity that you will get has disappeared. Now we are coming out of COVID. You also have weather pattern changes, global warming, so that the natural habitat for the mosquito is expanding as the world gets warmer and warmer and rainier. So it's a whole set of global factors, local factors, and post-COVID factors.
As Minister of Health, do you believe citizens are taking this seriously at this point in time?
Not all, some, but I continue to press citizens to do their part in source reduction. As we explained time and time again, spraying can only do so much, and it is not recommended to spray often. The main fight against the Aedes aegypti is within your homes, those vases that you have, those dish drainers that accumulate water, your flower pots, your gutterings, your water containers, your unused dog bowls. Those are the main sources. Wherever you have clean, clear, standing water, it's a primary source for the breeding of the Aedes aegypti. So we continue to ask people to work with us. The government will do its part, the ministry will do its part, insect vector, local government, but all that also depends on the citizenry protecting themselves within their properties.
I know the Ministry of Health, in collaboration with the Insect Vector Control Division, would have visited 150,000 homes plus at this point in time. Are we still seeing unkempt properties? Remind us of the fines and how many persons have actually gotten those fines and so on.
So they have actually visited now over 165,000 homes to advise people as to what to look out for and how to take care of their properties. The last figure I have of the number of notices issued will be 441, and what we are doing now is started to pay the second visits now. So if persons did not comply, well, the fines of $3,500 under the Yellow Fever Act will unfortunately have to start to apply. It's not something we want to do, but if we are to protect lives, we need to get serious about the way we engage homeowners, property owners, to help us in reducing sources of breeding.
So we are now moving into that phase where we actually fine people after the notices were sent.
That's right. That's what we are doing.
In terms of symptoms as it relates to dengue, what should people look out for?
Yeah. So the symptoms of dengue tend to be what we call flu-like. You get fevers, you get stomach aches, you may get diarrhea, you may get pain behind your eye, you might feel dizzy, typical flu-like symptoms. So that is why we ask people to come in as early as possible to get your blood tested, because the distinguishing factor between dengue and the regular flu is that your blood count, your platelet counts tend to drop quickly. And that could lead to, complications and ultimately death. So that is why we ask people, don't assume you have the flu. Assume you have dengue and come in as early as possible for us to treat you and make that differential.
After the pandemic, Minister, people would have thought we may not have seen other viruses pop up, but we continue to see many. We see Mpox right now. It's raging in Africa, as you said, and the Oropouche virus, which is very close to dengue. You would have recently spoke about that Oropouche virus being when the dengue is carried to test at CAFA. If it's negative, it goes to, how is that process going?
So we are testing. We have no confirmed cases of Oropouche virus in Trinidad and Tobago as yet. But we need to test because, again, the symptoms tend to be the same flu-like symptoms, whether it's dengue, whether it's Oropouche, whether it's influenza A, influenza B. The viruses tend to produce the same syndrome of signs and symptoms. Mpox is a bit different in that you get this rash all over your body with blisters and so on. So that one's a bit more easily differentiable.
Have we ever had the Oropouche virus in Trinidad and Tobago?
Yes, that's interesting. The Oropouche virus was first isolated in 1955 in La Vega de Oropouche, in a forestry worker. Hence the name, the Oropouche virus. It was named after the location. But we haven't had confirmed cases now for decades. What we are seeing is that confirmed cases are now rearing in South America, Cuba, and a couple other countries. And that is why we have to be careful to start to screen for that. And what we do, samples that are shown to be negative for dengue, then we do a second screen to see if in fact it is Oropouche virus. So again, we have to ask people to be very, very careful. Now, the vector or what carries Oropouche is slightly different to dengue. Oropouche is carried more by midges and other type of insects like that, not necessarily mosquitoes. But the signs and symptoms overlap. So it makes a clinical diagnosis difficult.
On the WHO's website, I saw it's midges and also mosquitoes, but if it's mosquitoes, does the Aedes aegypti also carry Oropouche? Has it been found to carry this?
I think in some countries they have found it, so that is why we are being careful here, especially now in parallel with dengue, right? So we have to be extremely careful. So what the population can do again is when you are going outside, wear long sleeves, long pants. Us men like to walk around the house in shorts alone and have your whole legs exposed and have your whole chest and back exposed. I think that is one of the things that we have to start to warn men against. And women too, keep yourself covered, especially when you are home, out in the yard early in the morning, watering plants, or out in the evening. Try and keep yourself covered as much as possible. Insect repellents, especially your children. I saw a picture of a baby. All the legs were bitten. Keep your baby in jumpers. Keep them as covered as possible.
Dr. Osafa Fraser from the IVCD, he would have said during some of the visits to the houses across the country that they're seeing some of these breeding sites in places that are very unusual, like in the bathroom, in the kitchen. Talk about this and how much of a concern is this?
So that is what they call cryptic breeding sites. Cryptic. It's kind of hidden. So those of you with sliding aluminum shower doors, those tracks, we are now finding Aedes aegypti larvae in those tracks where the water collects. We never used to see that before. And that's why we say spraying can't be the be-all or end-all. When we spray outside in the road, it's not going to reach there. We are now seeing people in their kitchens where they keep their dishes in their dish racks. Water collects there. The mosquitoes are breeding there in your kitchen. So all these are what we call cryptic or hidden breeding sites that we never saw before. So the mosquitoes seem to be seeking out new breeding sites. That is what is crucial to understand, that spraying is not the be-all and end-all. It is getting rid of any place as small as a bottle cap, where clean, clear, stagnant water could collect and where the female mosquito can lay her eggs. One small bottle cap can hold up to 1,000 eggs. Just that. Could you imagine what a plant saucer can hold? Millions. And that's what we are dealing with.
There's been some public concern on, the ministry and the local government actually cleaning drains. And I know a couple of weeks ago, you would have held a Ministry of Health conference talking about dirty water, with the Aedes aegypti actually living in that, and clean water. Could you explain this? And is it possible for the Aedes aegypti to live in these actual rivers and drains? And
so that's an excellent question to ask, because at the start of this season, unfortunately, people were being misled by taking the media to these drains and ponds and mossy ponds. The Aedes aegypti does not breed in dirty water. It breeds in clean, clear, stagnant water. So that is why we had to keep reminding people who were making these statements about clogged drains, rivers, ponds, mossy green ponds. The Aedes aegypti does not breed there. Other mosquitoes may breed there, but the Aedes aegypti only breeds in clean, clear, standing water, not in your dirty drains, not any drains that people may not be cleaning, where those drains are dirty. So we need to understand that.
Minister, you would have talked about, in terms of spraying not being the end game, but is there spraying taking place anywhere in the country?
Yeah.
In case if there's a suspected case of dengue, is spraying around that ring of persons as well?
So spraying has always been a part of the Insect Vector Control Division's activities. They would normally try to spray an area every 3 to 4 months, just as your natural background spraying. So it's not to say we don't spray. What we can't do is spray every 10 days, because the life cycle of a mosquito is every 10 days you get a new batch of adult mosquitoes coming up. You can't do that. So spraying does take place. And yes, once you have a confirmed case, let's say you have a confirmed case in this building, then you will rush in and spray around this building about a quarter-mile radius to do what we call break the chain of transmission. So in addition to normal spraying, when you have a case, a confirmed case, yes, you move in there, let the fire department put out that fire, and then wet everything around it for about a quarter-mile radius. Those are the strategies we employ.
Following this, the public has taken matters into their own hands by spraying some chemicals, and I understand one of them is malathion. Are we still seeing that taking place, and how dangerous is this for the public to do?
So insect vector also uses malathion. It is recommended, but it is recommended in very dilute doses and not to be used often. Why? Because it is dangerous to human health, especially if residents don't have the respirators. They can inhale this. It is dangerous to animal health, fish, birds, bees. So it is not recommended to spray malathion as you are using what in the old days we call flit. You remember flit? Now you might be too young to remember flit. The older people looking at might remember flit. But yes, any of your normal household sprays that you use, you don't do it like that on a daily basis. It is to be used strategically in a cycle so that resistance doesn't build up in the mosquitoes.
Are there public health protocols for when somebody shows up with symptoms at a public health facility that's similar to dengue? What's the protocols like?
Yeah, so there's a lot of misunderstanding. So what the physicians will do, they could make a very good diagnosis of dengue by clinical signs and symptoms. The type of fevers you have, where you have the pain, the vomiting, the nausea, dizziness, and so on. They will also draw a blood sample and do what is called a CBC, or a complete blood count, right? If they figure there's a high suspicion of dengue, they may then do a specific dengue test. But whilst they are doing that, they will treat you as if you had dengue, because they can make a pretty good diagnosis based on signs and symptoms, called a clinical diagnosis. So if we suspect you have dengue, you will be treated as if you had dengue. But there is no specific treatment for dengue. You treat the presenting symptoms. So if you are vomiting, you are given medication to stop the vomiting. If your blood pressure is low, they will treat that. If you have fever, they will treat that. They will treat whatever presenting symptoms you have.
In terms of persons actually having dengue, what kind of medication can they take? Is it, I know we said paracetamol, Panadol and those types of things like Panadine and so on. What should we not take and what should we take?
Yeah. So there's a class of drugs called NSAIDs. NSAIDs, non-steroidal anti-inflammatory drugs. That class of drugs, some of the common names that people will know is ibuprofen, the Advils, the Motrins, aspirin. You do not take those. Why? Because those drugs can cause bleeding. And one of the things about dengue is if you have severe hemorrhagic or bleeding dengue, that makes it worse. So you do not take NSAIDs, the Advils, the ibuprofens, the Motrins, the aspirins. The only safe drug to take is paracetamol, which is not an NSAID. So paracetamol for fever control, pain control. Do not take any of the other class of drugs that I have mentioned, Olfen, all those things. You do not take those. So dengue is not a reportable disease, but we have asked the labs to send us their figures, and most of the bigger labs are. So the figures that we give out is fairly accurate on a national level. So testing is taking place at both the public hospitals and the private labs. And they are cooperating with us to send us their figures, for which we are happy, because that gives us an idea of the national landscape.
What about the turnaround time in terms of this testing? Is it, are we seeing a efficient turnaround time of these?
Yeah. That can be done within hours. Yeah. CBC is done within 2 hours.
The amount of cases we're seeing, is it still concentrated in the south and central regions?
Yeah. So the 3 counties that were accounting for over 75% of the cases have been Victoria, Caroni, and St. Patrick, and that trend holds. It is mainly in south. When I first became Minister of Health back in 2015, it was more St. George West, Diego Martin, and for some reason now it is now shifted down to south and central Trinidad. We are yet to try to figure out why is that.
With testing, if a person is suspected to have died from dengue, do we still test that person, and how long does that take?
So as Dr. Hines explained, you draw a blood sample. That sample is sent to CARFA, and they have a turnaround time of about 2 weeks to make that confirmation. And that's why we say laboratory confirmed cases and laboratory confirmed deaths. We do not talk about suspected. We have to be absolutely sure. So I don't want to make the point because people are confusing the two. To confirm a death due to dengue takes about 2 weeks. Right. To confirm dengue in a living person does not take that. That's a matter of hours or a day at most.
Melissa, I want to jump to Mpox.
Sure.
Mpox and monkeypox, is it the same thing?
Yeah, so remember we had this discussion about the Oropouche virus. So that was back in 1955. What WHO has decided to do is not to stigmatize either a place. So they have changed the name from monkeypox to Mpox, because one of the worst things in this world is stigmatization. So that is one of the key reasons for changing the name from monkeypox to Mpox. So it has reared its head since 2022. But this particular strain, or clade, during COVID, people got accustomed to the term variants. So you can use the term variant in the monkeypox, in the Mpox. See, I just made the mistake. In the Mpox world, it is called a clade. What happened in 2022, the clade that was circulating then was called clade 2. What is circulating now is clade 1B. And this clade is much more easily transmittable, it's much more fatal, and the skin lesions and blisters that you get are all over your body. With clade 2 in 2022, it was not as transmissible, not as fatal, and the blisters you got were limited or localized around areas of contact, genitals, mouth, and so on. So that's a big difference between the two clades, clade 2 in 2022 and clade 1B circulated now. Clade 1B, worryingly, and this is why we are so concerned as health ministers, it is being transmitted now by casual contact. So, bed linens, a child sleeping in a bed after somebody with Mpox has slept there can pick it up. And what you are seeing now in families is a lot of children, unfortunately, are contracting clade 1B, as opposed to clade 2, where it was mainly adults. So many more children, because it's casual contact within the home. An adult brings it home, casual contact, the children are getting it. And remember, a child's immune system isn't as developed as an adult, so it's difficult for them to fight this off. So that is why one of the other reasons why clade 1B, the 2024 clade 1B, is so concerning.
We've seen this new variant, 1B Mpox, raging in Africa, on the African continent. We've seen it outside now, in Sweden, in Pakistan, and I suspect it will be in a couple of other countries by the end of this week. But how concerning is this as a health ministry in Trinidad and Tobago? How concerned should we be at this point in time?
I think persons who are in contact with people from the African continent should be concerned. So if you have a visitor who has been to Africa, you should be concerned. If you have a spouse who is working in Africa, coming back home, you should be concerned. If you are traveling in a plane from Africa, you should be concerned. The risk to the general open population is possibly not very high, but the risk to the individual and their families who have contact with people who have been to Africa could be much higher. And that is why we are so concerned. And if we as a global community must learn from the COVID experience, where rich countries hoarded COVID vaccines and did not make one single dose available to Africa, and Africa bore the brunt of that Delta wave of COVID, do you know the world is making the same mistake now again and not sending vaccines to Africa? One, the vaccines are very expensive. It's about €85 per dose. And I made a public call for first world countries who have hoarded millions of doses of Mpox vaccines to send them to Africa. Because it is no use you protecting yourself, but the fire is still raging there. Let's douse that fire before it reaches our homes. So I am again making a plea for two things. One, first world countries must share vaccines now. They have been making pledges, but not living up to those pledges. Two, the issue of technology transfer. The two companies that own the intellectual property to these vaccines, in my view, should make that intellectual property available now for free. Because they have admitted that they cannot supply the number of doses of vaccines that Africa needs right now. They have pledged 2 million doses by the end of 2024, but Africa needs somewhere between 20 to 50 million doses. So even if they get that 2 million, one, it's going to be too late, and two, it is not going to be enough. That is why I am appealing again to first world countries and those two companies that own the intellectual property, make vaccines available to Africa sooner rather than later.
Minister, you would have recently made a decision to increase screening at the ports in terms of temperature-wise and for the manifest coming from the African continent as well. How is that going so far? And is it at all ports? Is that at seaports and airports as well?
So it's mainly at airports. What we are concerned about now is air travel. That is going to be the main way in which Mpox is going to penetrate our borders, through air travel. Because from Africa to Trinidad, with one or two stops, you can be here in 48 hours. So I can leave Africa Tuesday and I am in Trinidad and Tobago on Thursday morning. So air travel is the main way in which our defenses are going to be breached.
You talked about it being about €85 for one vaccine. How many, do we have vaccines in the country for this Mpox virus, this strain?
Yeah, so when the outbreak, the 2022 clade 2 outbreak occurred in 2022-2023, we brought in 2,800 doses of the Bavarian Nordic vaccine. That is one of the two. And that cost us that price in the end. So 2,800 doses is a two-dose vaccine regime. So that means you can vaccinate 1,400 persons. So we have that. We only used about 14 doses in the 2022-23 when we had 4 persons with Mpox clade 2 in Trinidad. So basically we have all in hand in case we get some cases here.
Have talks started to procure more vaccines? And
yes.
Do you think we might get vaccines if we need it?
Yes, so 2 things. 1, yes, talks have started, but 2, our chances of getting more vaccines are very slim. Why? Because all the vaccines that are being manufactured have been pledged to Africa, where the fire is raging. And I think that's a good strategy. It doesn't make sense me hoarding vaccines and Africa doesn't have any.
If we have a passenger coming in from the African continent and the manifest says so, he shows up with a high temperature, what are the protocols in place at our local ports to ensure that it doesn't spread?
So it's the same protocols as, well, not same, similar as for COVID. I would have taken the media up to the airport during the COVID time to show you the medical facility. So there are isolation rooms and so on. So all that is in place. And then we can do contact tracing because now we know where you are going to stay, and so on. So the contact tracing could be done. The isolation can be done at the airport in case you have a suspect case.
Testing for this, do we have the capacity to do it?
Yes. So testing will be done at CARFA via what is called PCR testing. You take a sample of the fluids from any of the blisters. There are protocols to deal with that, wouldn't go into that here. And that sample is sent down to CARFA, and via PCR testing, the turnaround time for that is 48 to 72 hours. So the capacity for testing is there, the capacity for screening is there, testing, isolation.
Let's say, and I hope it doesn't come to this, we get a suspected case of Mpox. Do we have a facility to put that person in?
Yeah. So we have what are called isolation facilities with what is called negative pressure. Won't go into details, but basically when you are in a negative pressure room, the air in there cannot escape and go outside. So that contains, it goes a different place. So Cora has 4 negative pressure rooms. Each of the major new hospitals that we have built have negative pressure rooms. The older hospitals have isolation rooms. They may also have negative pressure rooms. So the answer is yes, there is a lot of capacity with negative pressure rooms and isolation rooms in case we get a case of Mpox clade 1B.
Minister, you could confirm or deny, but I heard a rumor, and it's just a rumor, that the Cuba Health facility could be possibly turned into an Mpox facility, just like we had in COVID, like a separate step-down facility and so on.
So I don't think that's something we could consider right now, because we have the other facilities. As I said, we have Cora, We have isolation rooms in other hospitals. But let's see what evolves. What we are using CUVA for now is for both COVID and dengue.
Minister, I want to talk about robots, and I'm putting it just like that. But recently, the Ministry of Health would have received about 6+2, 2 disinfecting and 2 HSRs in terms of health service robots from the Indian government, from PAHO WHO, to the tune of about US $1 million.
Yes.
How are these going to be used in the public sector?
So it's 2 types of robots, as you rightly said. One is 2 are disinfectant. So what they will be used for, so let's take Mpox. Suppose you have to disinfect the room that the Mpox patient is in. It may be better to use that than a person. So the disinfecting robots could be used in situations where you may not want a person actually going in to do it. The other health service robots are there to provide administrative support. They are also useful in disseminating information because it is linked to the Ministry of Health's website. So anybody can go to the robot. You could place it in a hospital. Members of the public can go there and automatically link to our Ministry of Health's website. So for example, you want to know the county medical officer for a particular county, contact details, insect vector. It's there. You want to report, you want to get your place sprayed, there's a confirmed case of dengue, it's there. So it's going to lend a lot of administrative support. And I think it's a good way to start to introduce into the public health system more advanced technology as we have to move towards being more technologically savvy and incorporate things like artificial intelligence into our operations. So I think it's a good addition to what we are doing.
I saw some public comments following the launch of the robots, the health service robots. Some of them showing some concern about whether these robots would actually operate on some persons. I know it's strictly for administrative purposes, but is that the way of the future in terms of AI, in terms of taking temperature from persons and so on?
Yeah, that is going to be the way of the future. So what that will do is, so let me say, these robots are not operating on people. Let me make that abundantly clear. You know how we are with conspiracy theories. Yeah, so more and more health systems are utilizing technology to take away the administrative chores from doctors and nurses. Not only doctors and nurses, doctors, nurses, lab techs, who have to generate, who have to do all these millions of tests. So if we can take away a lot of that administrative burden from those frontline healthcare workers, it can only be a good thing for health and let people focus on diagnosis, looking at people, talking to people, doing their clinical work and so on. They are not here to replace people. They are here to help healthcare workers take away a lot of the drudgery, the repetitive tasks and so on. We can't be afraid of technology. We must adopt technology. But there will always be a role for people. And you must remember, the world even pre-COVID, but COVID exacerbated it. There's a global shortage of healthcare workers, post-COVID, of all classes. Lab techs, nurses' aides, nurses, doctors. So anything we can do to help people is welcome in the system.
There's always a reluctance from the elderly population to embrace technology, even to use a credit card or links. They like to go physically inside the bank. But how user-friendly are these robots in terms of the elderly population actually interacting with them and implementing some of these administrative information?
Oh, it's very easy to use. It's very what you call intuitive. You look at the screen, it's a touch screen. It's like how we use our iPad. It's how we use a cell phone. So I don't anticipate much resistance there. Of course, like everything else, but I think it will be welcomed by all.
Recently, we would have seen this Shade House program launched in Tucker Valley. The Prime Minister had a lengthy speech where he talked about NCDs and these sorts of produce, high quality produce that could eventually lead to us eating healthier. As the Ministry of Health, do you embrace this?
Of course, anything that that causes people to engage in behavior change, from eating unhealthily to being healthy, I am all for it. And we must start to embrace more natural foods and start to wean ourselves off from these highly processed food, sugary drinks, caffeinated sugary drinks, all the fried chicken and fries and hamburgers that we eat every day. I keep saying, it is not that you should stop eating those things, but do everything in some degree of moderation. Doubles every morning for breakfast is not good for you. Doubles every day for lunch is not good for you. Chicken and chips every day is not good for you. Pizza every day is not good for you. 3 Pepsis a day is not good for you. 3 Coke a day is not good for you. Moderation. Start to wean yourself off of these things, and you will live a much healthier life.
I will try to cut down the doubles to once a week, but in terms of...
Talking about that, I am overdue for doubles. I haven't had one in about 3 months, so I'm overdue for one.
Wow. Minister, we would have recently seen the Point Fortin Hospital become a baby-friendly hospital. What does this mean?
Yeah, so that is one of the achievements we at the Ministry of Health are most proud of. One of the reasons for high rates of NCDs is because we have moved away from breastfeeding to bottle feeding, formula feeding, which is based on cow's milk. And the babies of today don't get the benefit of breast milk. They don't get the benefit of all the antibodies. They don't get the benefit of all the proteins and good fats and everything else. All they get are the disbenefits of formula. And they get the disbenefits of unethical marketing practices by baby milk formula manufacturers and retailers. And we as a society have been brainwashed over the past maybe 40, 50 years to think that convenience of a bottle is superior to breast milk. We came up with a national breastfeeding policy in about 2020, which told us that we needed to ramp up our breastfeeding rates. And I'm happy to say that now in our public hospitals, 90% or 95% of our mothers start to breastfeed within 2 hours of giving birth. We never had those figures before. And the breastfeeding initiative, called the Baby Friendly Hospital Initiative, BFHI, is a 10-step certification program through PAHO that tells you that you have all the policies and practice in place. So mothers giving birth in your hospitals understand the importance of giving your baby breast milk from as early as possible and for as long as possible. And if we are talking about NCDs, a healthy mother breastfeeding a baby, that baby is less likely to develop diabetes as a child, less likely to be an adolescent diabetic and an adult diabetic. So breastfeeding is something that we took for granted when my grandmother, when my mother were doing it, but with modern living, we called it progress, moving from breast to bottle. Moving from breast to bottle is not progress. Nobody wins, especially that baby. So we are trying to encourage our mothers to breastfeed as early as possible and for as long as possible. There are 3 P's in breastfeeding that we need to teach mothers: patience, practice, perseverance. You have to be patient. You have to practice the technique. And then once you practice it and learn it, you have to persevere with it. And you will overcome those hurdles. We understand that. And we teach them that. We teach our mothers that. We have nursing educators that actually teach mothers the correct technique for breastfeeding now.
Did the ministry achieve its goals for the financial year, and what can we expect in the upcoming financial year?
Yeah, so we set some specific goals for maternal mortality rates. We accomplished that. We set goals for neonatal mortality rates. We accomplished that. We set some goals for NCDs to bring down the rates of high blood pressure. We accomplished that. We accomplished a very significant figure in bringing down the rate of major lower limb amputations due to diabetes. In our first year of operations, and I'm saying this for the first time publicly, we have decreased the rate of amputations, major lower limb amputations, by 16%. That is a tremendous achievement because of our diabetes wellness clinics in teaching people how to manage their diabetes. So less people are having limbs amputated. That's a major, major achievement.
What continues to be a major challenge for you other than the opposition that always seems to
No,
criticize?
I totally ignore the opposition. I don't have time for them. And, when the opposition, then in government, had to deal with Ebola, I was an opposition MP. And, I never criticized them because I understood the science. I understood public health. And I understood that for a government, for a people to succeed in a time of a pandemic, you need the whole country pointed in one direction. And when Dr. Fuad Khan and the UNC were dealing with the threat of Ebola, you would never have heard me raise my voice once in opposition to any of the preparations they were doing, because I understood, one, the science, and two, I understood that we are all in this together. And as an opposition member, you didn't want me doing what they are doing and what they did during COVID and dengue. It does not help the country. In a time of crisis, a country needs to speak with one voice. You put aside all your tribal politics, because when you don't do that, people die. People don't know who to listen to. So I never played politics with Ebola. Never. I was in the parliament. But the opposition is the opposition.
A couple of weeks ago, following Joe Biden's resignation, I believe he said that he got COVID. Do we still have COVID here in Trinidad and Tobago?
No. We have COVID in the world. COVID is still an issue around the world, albeit at a much lower level. It is no longer threatening countries. It is no longer threatening health institutions by overwhelming them. But COVID is going to be with us just like the flu, just like dengue, just like measles. It is going to become a part of the public health landscape that we have to learn to live with. Thankfully, the Omicron variant, which emerged in January of 2022, to me that was a savior, because that variant was much milder, so it infected everybody, and so you got a sense of natural immunity being built up, as opposed to Delta, which was much more deadly. So people who didn't want to be vaccinated had no choice when they got the other variant, which was much milder, the Omicron. That acted as a type of natural immunity. So COVID is here, possibly here to stay, and yes, we are still seeing cases. I believe in Couva we still have 2 cases.
Just to confirm, do we still test for COVID?
Yes, we do. Yes, we do.
Is it via PCR?
Yeah. Plus now, you have the rapid test, which is much more convenient, and you get the results in 15 minutes. So we still test for COVID.
Minister, as we wrap up, I just want to ask you one question. You recently launched a certain for men's health. There was a rapid test for men's health.
Yeah.
Talk to us about that.
So for the first time in Trinidad, so let's go back. Prostate cancer is the #1 cause of death of cancers in men. especially amongst African men. We have a particularly difficult type of prostate cancer in the Caribbean amongst the African population. The test before, you took a blood sample from the vein, send it to a lab, you wait weeks, months to get back the results. This rapid test now is similar to the rapid COVID test or pregnancy test. You just put 2 drops of blood and you get the results within 10 minutes. What that test does, it has a cutoff of 4. 4 and below is negative, you get 1 line. 4 and above is positive, you get 2 lines. So if you get 2 lines, which about 10% of the men got, we then send you for further care, for further investigation, to see if it is really cancerous or not. So it's a very good quick screening tool, and we'll be doing more of that screening in coming weeks and months for men.
Do you expect this to be a game changer for men in terms of getting that the amount of cases of prostate cancer down?
Yeah, it is, because men traditionally don't like to seek out medical care. Men have this fear, especially about prostate being tested, because they don't like the digital rectal exam. So this gives you a much more convenient way of understanding where you are with your PSA levels. So we are going to be doing a lot more of it. It's the first time it's being used in Trinidad and Tobago, and it has generated a lot of excitement amongst the male population. So anybody over 40 or 50, whenever you hear we have it again, it's going to be out again soon in locations around the country. Come out, get tested, know your status.
Your closing remarks?
Closing remarks. As Minister of Health now for going into 9 years, I continue to be amazed at the dedication of our healthcare workers. I don't want to single out any group. They are all wonderful people. They go beyond the call of duty to serve this country. And I will keep saying it, although people don't understand it. This healthcare system that we take for granted, the services you get here for no cost at the time of delivery. In other so-called first world countries, if you don't have insurance, you will die. If you don't have money and wealthy, you cannot access the type of services that we give here. And I really want the population to understand that no healthcare system is perfect anywhere in the world, but ours is a lot better than many first world countries. Let us continue to cherish it. Let us admit when we do something that may be off the charts. As all healthcare systems, we are not perfect. People are not perfect. But I keep saying our healthcare system is one of the best in the world. And I thank everyone, all 20,000 healthcare workers who come out every day to only do their best for their patients.
Minister, thanks very much for joining us. I know we've barely scratched the surface on some of the issues in terms of we have dengue, Mpox, the Oropouche virus, and COVID as well, and so much more. But thanks for joining us. We would need to have you back on the show, I guess, before the end of the year, because as Mpox and this Oropouche virus continues, I know it's very fluid indeed, and I do hope you get to eat that doubles after.
I will try. Thank you very much, Sunil.
Join us at the same time next week for another episode of Delving Deeper. I am Sunil Lalla. On behalf of the entire crew, have a great night.